It's a pleasure to be here. Greetings from Philadelphia, Pennsylvania. I want to thank the Planning Committee for this invitation to speak. And I want to thank Catherine Dawson for essentially foretelling my presentation. I'm a geriatrician. I co-direct the Memory Center where I take care of patients. Also relevant, I think, to my background is that I am a site PI for some clinical trials done to test drugs in individuals either at biomarker-defined risk of Alzheimer's or who have a diagnosis of either MCI or dementia caused by Alzheimer's. I have no IP and paid consulting relationships. Why do people enroll in trials? This is a very well-studied area. There's not, if one said I want to do a study to figure out why do people enroll in research, I'd need to hear more about the design and the research questions, excuse me, in particular to say why it should be done. The decision is a personal decision, of course. I'll start with that conceptual point. That is to say, it's a decision that's based on preference and values. There's no inherently right or wrong answer as to whether you should enroll. This is a decision that fits into that category of in matters of taste. There should be no disputation. Studies done since the 1990s have shown that it's a multi-attribute decision that balances amongst three broad categories. Number one, emotions and feelings and values of trust. Number two, emotions, feelings, and values of altruism. And finally, some expectation of benefit. I'll develop each of these points in greater detail. Trust, we have found, and other studies, several studies, is contextualized into several strata, or components, if you will. The general sense of trust in the research enterprise. Research is a social good. A trust in the researcher, namely the individual whose name is at the top of the consent form. A trust in the institution where that research is being done, and I can tell you as well, data has shown even in the sponsor. The second is feelings of altruism. Again, bounded by certain, if you will, strata or defined by certain strata or spheres. People like me, people in my family, older adults, for example, often speak of, I know I won't be around, but my children, I hope, will be around, or my grandchildren to benefit from my participation in this. And finally, some have a sense of altruism, which expands beyond very identifiable groups to just, I want to help humans. And then finally, some expectation of benefit to one's health, or at least no harm to it. Some expectation of benefit from the compensation that we received. Or it's viewed as a pleasant event. It's something enjoyable to do. I like the study staff. They're good people. In some of our subjects at Penn Memory Center studies, one of them remarked to me, I see your coordinator more often than I see my own daughter. And the relationship we have in some sense is the same as that relationship I have with her, in some sense. Well, let me develop this point a little bit more. We developed a scale called the Research Attitudes Questionnaire. It's a 7-item scale that asks people to strongly agree to strongly disagree, so you get a metric measure. I won't read each of the items there, but I think what we tried to do is sort of capture these general attitudes that I spoke about in the prior slide around trust and medicine and research, etc. I have a positive view about medical research. Researchers can be trusted. Attitudes about benefit and research that's generally safe, etc. So across several studies, we've had folks fill this out, and we found it to be a very strong predictor of willingness to participate in clinical trials, as well as remaining in the studies and doing sub-studies. And the point I'm getting at here is just simply to validate what was found from a variety of qualitative studies of actual participants with this metric measure. And this is a study that we did where what I've plotted on the x-axis is the scores on the Research Attitudes Questionnaire, and on the y-axis, the predicted probability of I can move something on my screen here so I can see my slide. The predicted probability of people endorsing one of 4 of those response options. These were individuals who were presented a clinical trial for persons with Alzheimer's disease, dementia, and we were asked them their willingness to enroll in the trial from definitely not to definitely yes. And so what I'll show you on the next slide is how scores on this questionnaire of research attitudes derived from that qualitative work predicted whether someone would endorse definitely not, probably yes, or definitely yes. It's a bit busy, that's why I walked you into this, but if you just say start with the definitely not group here, you can see at those low scores, the odds are quite high of saying definitely not and quite low about saying I would. And I think the curves really behave in a very logical and sensible way. That is to say, you can begin to see almost a cutoff on the RIQ where the likelihood of someone saying yes to the particular study, in this case that they were shown, was quite high, and their likelihood of saying no was quite low. So what's my summary point here? Multiple studies have shown attitudes of trust, altruism, and expectation of benefit are amenable, are what drive people to make a decision to enroll in a specific study. Of course, the next question that follows from that is, can we engage in interventions that would change someone's trust, altruism, expectations of benefit so that they would flip from saying no to saying yes? And we've looked at that a bit. I'll develop some of the conceptual points around that. I want to focus particularly on matters.
Pardon me, Jason?
Yes?
I guess, is there, I think you're a little bit muffled. Is there a way you can, is there anything on your mic or anything like that? You're coming across.
No, but I can turn up my volume. How's that? I'm talking now with a higher volume.
Yeah, maybe I just try to speak more into the mic might help. It's just coming off a little bit. Thank you.
All right. I'd like to develop more, particularly on the perception that research can be beneficial or at least not harmful. First, I want to put out a conceptual point. Research is work. It is asking someone to participate in a work activity. That's why we pay people to be in studies. We don't pay them to come in for clinical care, but we do pay them to come in for a research visit. Several studies have identified that among the features of that work and perceptions of it as being labor is the travel to the study site and the time required to be in the research. I'd like to now focus a bit on older adults who, because of physical or cognitive impairments or a combination of them, especially persons over 75, can experience inefficiencies in performing their instrumental activities of daily living. I'm saying just plain fact there, I hope. Well, of course, travel and participating in research should be thought of in some sense as an IADL. It's a work IADL, if you will. And so if you're seeking to enroll older adults into your studies, particularly persons over 75, you're asking them to engage in an IADL, which they may have trouble performing. Many solve that or address that challenge by asking someone else to help out. We often call these people caregivers, an emerging term now, as well as care partner. So I just want to put out a question then, or a hypothesis, which is, if you modify the attributes of a clinical trial, can you adjust people's willingness to participate, particularly these attributes that sort of surround the work of a trial? And we did, and others have done research that shows matters of travel, as well as the risk of a drug and the chance of receiving the experimental treatment versus a placebo are typically things that people bring up repeatedly, as Catherine Dawson, for example, cited in her presentation as to barriers to why they'd enroll in a study. Location of the study visit obviously then becomes contextual to each individual. How far do I have to travel to get there? And how do I get there? Car, drive, someone drives me, public transport, etc. And so I want to show you the results of some work that we did. These were with individuals who are caregivers, care partners of persons with dementia, where we gave them an Alzheimer's disease dementia study description and asked them to consider variations on a theme of where the study occurred. All the visits were at Penn, or all the visits, 2 of the visits were at Penn, and in between we come to your home. Like we do for medical care, we can do home visits for medical care. All the visits required you to get there, however you choose to get there, versus we'll send a car service out to bring you in. We varied the risk of the drug, and we varied the chance of receiving the experimental treatment versus placebo. Now, what we did was a method in marketing research called Conjoint analysis, where people, and here's an example of a subject in that, each of these cards showed the various possible combinations of those attributes, and she's ranking each one from definitely would participate to definitely would not participate in that study. And the result then is this table here, which I'll spend some time developing. So,
Hi, Jason, pardon me, just giving you your 2-minute warning.
Right. What we see here, What we see here is if it's a negative utility, it's taking her down from wanting to be in the study. And if it's positive utility, it's increasing the willingness to participate. And what I hope you can see here is that a home visit takes someone from being, say, a 5 to a 6 on that utility scale. It increases their likelihood by a pretty decent amount. A car service is good, but it's not as good as coming to your home. It's nice to see, of course, that higher risk decreases people's willingness to enroll. So what's my point? Not to get too hung up in the specifics of this study, but to say that the general point here is that if you manipulate the aspects of the work of being in a clinical trial, you can manipulate someone's willingness to participate, recognizing, of course, that trust and altruism are also important factors to this decision to be in a clinical trial. We found that reducing the burden of travel by the home visits was especially viable for family members who were caring for patients who had more instrumental activities of daily living impairments and or behavioral problems measured on standard metric scales. So I want to talk a bit about some solutions. Well, back to my opening points about trust and altruism. I think it's an open question. Could we create messages, the sorts of things we do in the world of public health, that educate and empower people about the value of research? I think we should think about this because studies tend to suggest that older adults may be more altruistic than younger adults. One thing we know about the psychology of aging is that the more someone's chronologic time clock is ticking, I guess, down, the more they're present focused, the more that they're looking for activities which in the present are pleasant and not thinking about a stressful future. Younger adults, in contrast, love horror movies. We should think carefully, very carefully, and discern what is the work that's being asked of someone to be in a clinical trial. How often are the visits? Where will the visits be? How long will the visits take? What will be the interval between one visit and the next visit? That's the work of research, and we have to think very carefully about how we're compensating people for that work. We should be considering things, for example, like home visits or other steps that might reduce time and travel. These are all empirically testable, as I hope I've showed you. And then finally, I think much greater attention is needed towards the role of the study partner. That is to say, that person often unacknowledged outside of the neurodegenerative disease space, particularly Alzheimer's disease, but still very present, seemingly almost naturalistic in the case of spouses, and yet even in the case of a spouse, they're doing work as well, bringing their relative in, helping them out, figuring out the visits, etc. This person may also be a friend or family member, etc. We should acknowledge that person's role and think about whether we should be also compensating them for the work that they're engaging in to participate in a study. Those are the ends of my remarks. I believe I am also the end of this panel. And so now I'll turn it back over to my moderator, who I think will take it from there.